Welcome everybody this evening. We're really pleased to be presenting this free webinar today, and we're really glad that you could join us. My name is Kristen Kovach-Bentley, and I am the Communications Manager for the Retired Racehorse Project, which is a 501c3 nonprofit dedicated to increasing demand for thoroughbreds beyond racing. We consider education a key component of increasing that demand by empowering the public with the tools that it needs to be successful with off-track thoroughbreds. This webinar is being recorded and it's going to be added to our free online education library, which you can find at our website, along with hundreds of other articles and recordings at therrp.org/library. Tonight's webinar is made possible thanks to the generosity of our sponsor, Bluegrass Equine Surgery. We're very grateful for the support of our sponsors and donors who make all of our work possible. I'm excited this evening to introduce our speaker, Dr. Heath Manning, who grew up in Glasgow, Kentucky, went to undergrad at Georgia Southern University, and then went on to vet school at Ross University. He completed an internship after vet school at the Cornell Ruffian Equine Specialists on Long Island, and then a second internship at Texas A&M, where he was fortunate enough to stay for a surgery residency. There, he was exposed to all facets of equine surgery and developed a keen interest in equine orthopedics, particularly fracture repair. He recently moved back to Kentucky to start practicing surgery at Bluegrass Equine Surgery in Versailles. So Dr. Manning's expertise is in surgery, but he's really excited to speak on our topic tonight, which is diagnose before you treat. And we're going to take a kind of a high-level look at a few common issues with off-track thoroughbreds. So Dr. Manning, I'm going to turn it over to you.
Thank you, Kristen. So as Kristen mentioned, we're going to talk about some pretty common issues in the thoroughbred, the off-the-track thoroughbred racehorse, and what they can experience, and kind of go through in the first year off of the track. A bit of a basic overview is we'll cover equine gastric ulcer syndrome. Many people are very familiar with this. There are two different subsets of gastric ulcer syndrome. I'll very briefly touch on those. As Kristen mentioned, I am a residency trained surgeon and not an internist, so my pathophysiology is a bit lacking for this disease process. We'll then move on to some commonly encountered foot issues that can be experienced, particularly in the off-the-track thoroughbred, and specifically thin-soled horses that come out of a performance environment, always in shoes, and become tender-footed right out of the gate off of the track, which can lead to some other common abnormalities within the foot, such as subsolar abscessation or septic pedal osteitis, which I'll briefly touch on as well. And then finally, we'll wrap it up with impingement of the dorsal spinous process, or overriding dorsal spinous process, commonly referred to as kissing spines. And we'll go into a more in-depth look at this disease process, because this is where I'm formally trained, and there's some really interesting information and literature out there that we'll cover that leads you to think that it's not always the back. So a brief overview: equine gastric ulcer syndrome typically involves the distal esophagus, right at the cardia of the stomach, and then traces down the stomach lining into the squamous portion, as well as the glandular region, and it can often affect the proximal duodenum. So here is in the schematic on the right. This is our distal esophagus. This is where the food bolus empties from the esophagus into the stomach. And then there's this clear demarcation here between the two regions of the stomach. And at the top, we have this white in appearance portion, which is the squamous portion of the stomach. It does not produce acid or pepsin in its function. It strictly is just the pyloric, or the fundus of the stomach, where the food bolus is housed, while the digestion occurs in the glandular portion here in the ventral aspect of the stomach. This is where the acid is produced and secreted. This is where the ingesta is then mixed with saliva, and then it is emptied out the pyloric region here into the small intestine, which is known as the duodenum. It is very well documented that the thoroughbred racehorse is significantly prone to gastric ulceration. Some studies have found up to 100% of all thoroughbreds in training experience this. These are performance athletes. They're in high pressure, high demand situations, and they're really pushed to their limits. So that's really no surprise there. Unfortunately, some of those horses carry these vices when they go off of the track, and still can be a bit stressy, given their upbringing, and are still predisposed to gastric ulceration, even more so than your average pleasure performance horse that wasn't a thoroughbred racehorse. Particularly of note, this study here at the bottom was published a few years back out of Australia, and noticed an 86% occurrence rate of gastric ulceration. Now, to note, both regions of the stomach, the squamous and the glandular portion of the stomach, are prone to ulceration. Treatments are a bit different. We'll get into that. But more commonly, when you think of gastric ulceration, you think of the squamous portion being ulcerated. Again, this is on the right, a post-mortem photograph of a horse's stomach. You can see this clear demarcation of the two portions. And this is the the squamous portion. It's covered in squamous cells. So it has more of a epithelial-like texture compared to the glandular portion of the stomach, which is comprised of parietal and chief cells that secrete the actual acid and pepsin for digestion. And it has a softer characteristic to it. So some reasons why these horses get ulceration, and we don't know exactly why, but we've honed in on a few reasons that seem to contribute to the ulceration in the horse's stomach. And that's changes in exposure or types of gastric acid. As we look at the gastric contents, we know that the most acidic portion of the gastric juice is in the ventral glandular portion, and that pH only rises or becomes less acidic as we move more closely to the squamous portion of the stomach. And the reason for this is kind of multifaceted. The acid is produced in the most ventral aspect in the glandular stomach, so it is naturally going to be the strongest where it is excreted from these cells. And then we have the addition of saliva from the esophagus that's produced in the mouth, which is very rich in bicarbonate, which is actually a buffer and is alkaline in nature. So the most alkaline portion is actually going to be this top bolus mat of ingesta within the stomach. And there's a range of acid concentrations throughout this. These pHs can change for a variety of different reasons. If there's a pyloric outflow obstruction where food can't empty the stomach into the small intestine, that acid builds up in the stomach, and you can get lesions like this that are created in the lesser curvature. So this is on the far side of the stomach. You can see this is where the esophagus is emptying into the stomach. This is the scope's camera right here that is attached to the end, creating this picture. The lesser curvature, and then the pylorus is down here under this ingesta. So pyloric outflow obstructions can lead to lesions similar to this. Other stresses that these horses encounter include the show season, where we're asking them to perform at their highest level and really pushing them hard. These are performance athletes. They stress just like we do, and get stressed when it's time to trailer to a show or performance. Trailering in and of itself, some horses just don't like to trailer. I think we all know horses that refuse to get on the trailer or get off of the trailer once they're on it. And this can predispose them to gastric ulceration. Every herd has a hierarchy. There's always the most dominant, and then there's always the one that misses out on all of the feed. Sometimes these horses are bullied at pasture, and the herd hierarchy is actually predisposing them to these gastric ulcerations. NSAIDs. I've listed here the three most commonly used NSAIDs: bute, banamine, equiox. While in theory, phenylbutazone is regarded as probably the most gastrotoxic when it comes to ulcerations, some new evidence is coming out that says that equiox really might not be as mucosally safe as once thought. So there's still some interesting ongoing investigation into that that's going to help the horse. And these drugs also have a detrimental effect on prostaglandin production, not just in the stomach, but throughout the entire body. Prostaglandins are very important in the overturning of the mucosa, which lines not only the stomach, but it lines the entire gastrointestinal tract. This can then predispose them to hindgut ulcers, which, is a perpetual cycle of ulcers and NSAIDs. Management of these horses, again, this kind of ties back into the show season, but the frequency and intensity at which these horses train, they only become more stressed as both of those variables increase throughout their career. Some other variables that might play a role in equine gastric ulcer syndrome, the stressy horse. I think we all know a horse that seems to be stressed out over no reason, whether that's at home, in the pasture, in the hospital environment, no matter what, it's just considered a stressy horse. Clinical signs of equine gastric ulcer syndrome, the mild chronic intermittent colic is definitely a classic sign. Just not quite right, still eats, but is off, pause. Inappetence, they all of a sudden refuse to eat. That is an indication that it could be equine gastric ulcer syndrome, because when they eat that roughage or that grass, their physiology tells them to produce more acid to digest it. Horses are herd graze animals, so they're constantly eating. They eat up to 18 hours a day if turned out. So they also actively have to digest food. Behavior issues are often experienced. One of these is girthiness that we'll talk about. They refuse to do something, everyone wishes they could be in the mind of a horse, but sometimes behavior that they didn't exhibit before, they exhibit now because they've had a stressful event, and they become a victim of ulcers. Poor performance in these high performance horses, either the Western performance or the performance thoroughbreds or race horses of all breeds. Maybe at one point they were fast and now their speed scores have dropped, or their show scores have dropped, and you can't get to the bottom of it. The horse isn't lame. Something just doesn't make sense. Certainly could be pain from gastric ulcers. And that ties into reluctance to train. Even when your training regimen was on point and ready to go for the next show, the horse just kind of falls flat leading up to the next event. And then poor body condition, hair coat, that's definitely one that's typically seen later stage or increased ulcer scores. And that's chronic in nature. Over time, these horses, it hurts to eat because they have that gastric juice production, and then their body condition starts to diminish. Their hair coat becomes dull, and then they don't look good. So to diagnose gastric ulcers, there's really two different ways. The gold standard is gastroscopy, and it's where we put this instrument, it's a 3-meter endoscope or gastroscope. We put it into the nose and pass it into the esophagus, and then run from the esophagus all the way to the stomach and take a look. And it's really a benign procedure by and large. We fast them for 16 to 18 hours prior to putting the scope in there, because we don't want any ingesta within the stomach, so we can really evaluate all of the walls, sedate the horse, and then pass the scope, as I mentioned, through the nose and down into the stomach. Then we distend the stomach with air, and that kind of inflates it like a balloon so that it's not collapsed down on itself. And then we can take a look around and we can look at all aspects. And in most cases, we can even pass the scope down through the pylorus and into the duodenum and take a look. It's very well tolerated, as I mentioned. There are very few complications. Sometimes immediately after, these horses will have a little bit of air and get a little bit of a bellyache, but it's really nothing that is too malevolent. And you get immediate results. So it's all real time, live. you see what's going on. You don't have to wait. So you can immediately see that the stomach is either ulcerated or not. And then you can implement treatment as soon as the scope is out of the horse. This is just kind of a schematic of what happens. So the scope is passed through the nose into the oropharynx, and then the horse swallows the scope, and we pass it down into the esophagus. This middle picture is kind of a view of what the esophagus looks like. It's folded over, and there's a lot of mucosal folds so that esophagus can expand as a food bolus is moving from the mouth to the stomach. And there's always peristaltic waves of that esophagus as you're moving through. And we like to evaluate the esophagus just to make sure there are no diverticular strictures, something that could predispose the horse to a choke episode, anything abnormal like that. And then in this top right picture, this is what a normal, healthy, pristine stomach looks like. There's clear demarcation of the margo plicatus. At the top here, the white area, we have the squamous portion of the stomach, and then this pink area is the glandular portion of the stomach. In this bottom right picture, this is an area that's ulcerated right at the margo plicatus. These small multifocal red areas or plaques are gastric ulcerations. And these are what are causing pain. It's kind of like having an open wound that you rub salt in every time those gastric juices hit it. And it can be quite painful. As far as treatment is concerned for gastric ulcer syndrome, pharmaceutical treatment is indicated, and there's a variety of different drugs on the market that we can use. Antacids, either aluminum hydroxide or calcium carbonate. These are brand name or just drug names, but there are some brand names within the pharmacies that we take as humans. These in theory work in the horse, but as you can imagine, the size difference, they aren't practical to use because it would take a lot of antacid to treat the horse, and they would need to have it as frequently as every 2 hours to treat those symptoms. You might be familiar with a drug called sucralfate. It's an ammonium hydroxide protectant. Really, it binds to the open ulcerations and kind of protects them. And here in the middle, or excuse me, here on the right, I have what is supposed to be a schematic of a cell, a gastric cell. And at the top here, we have the inside of the stomach, or the lumen. And this black box represents the cell. This MB barrier is the mucosal bicarbonate barrier, and this is being constantly turned over within the horse's stomach. So the mucosa is produced and is degraded as it moves toward the lumen by the gastric acid, which is this hydrochloric acid and pepsin. So these move outward as it tries to fight inward. And if the lumen or the acid overcome this barrier, then we have exposure to the underlying membrane, which creates an ulcer, a gastric ulcer. So the antacids just decrease the production of the acid. They counteract it, really. The sucralfate, when this barrier has been broken, provides a protective layer so that the acid can't get through to it, and it acts on the mucosal bicarbonate barrier. The next pharmaceutical that we can use for the treatment of ulcers are proton pump inhibitors. Omeprazole is the most commonly used, GastroGuard or UlcerGuard. That's because they're proven to be efficient in the horse and efficacious. But there are some others out there, Nexium, which is esomeprazole. There have been some studies done on it. The problem with that particular drug is that it has to enter the horse's mouth in tablet form. If it's chewed, then it's completely ineffective as it reaches the stomach and won't work. Misoprostol is a prostaglandin analog and is used for glandular ulceration. The lack of prostaglandin in that region increases the likelihood that you're going to get glandular ulceration because As I mentioned, the prostaglandin is used for that mucosal overturn, where it's constantly produced, and then you get lack of that mucosal bicarbonate barrier. Some other drugs that are out there, ranitidine or famotidine, those act at a different location, and they actually decrease the actual production of the hydrochloric acid on the level of the cell. So they act on the parietal cells and slow down the exchange of the potassium proton pump exhibited here that creates this hydrogen chloride. Other treatments are management. So if you've ever had an ulcer, you're likely stressed and taking NSAIDs at the same time, and it begins to hurt. The quickest way to alleviate that is to decrease the stress, decrease the production of that cortisol, and allow your stomach to overturn that mucosal barrier. Another protective mechanism is increase the roughage. A constant stomach full of feed helps protect that barrier, because as they chew, they're producing saliva. Saliva is a buffer because of the bicarbonate, which decreases the gastric acid content, or the gastric acid pH, I should say. Alfalfa is another good roughage intake. It's high in calcium, so it helps decrease it. And again, it fills their stomach, so they have a full belly, decreased gastric pH. Prevention really ties back into treatment. It's multifactorial. The management of these horses is really important. Stressful events, continuous turnout, pasture mates. These are herd animals. They don't like to be alone. So turnout with the pasture mate, free choice roughage, keeping that belly full, as I mentioned, and alfalfa, exercise timing, maximal provides maximal intragastric buffering. So if you exercise your horse in the afternoon after they've been eating all day, they're less likely to succumb to the pain of these gastric ulcers, because that food bolus that is within their stomach is buffering the acid. Maximal effort of exercise should be kept to a minimum. These horses are athletes. They have jobs. They need to perform. They need to earn. But leading up to these stressful events, they shouldn't be run into the ground as far as their exercise regimen, for a variety of reasons, one of which is gastric ulcers. High concentrate feed, the grains are really important. These just propagate the gastric ulcers. They increase the gastric pH, and it becomes a perpetual cycle with the mucosal damage. So some nutraceuticals that are out there, everyone probably has anecdotal information about what works and what doesn't. So I thought I would include some of these just to touch base on some evidence that's out there regarding some crazy information. Corn oil, that's certainly a nutraceutical. It's cheap, it's easy to get. You might even have it in your house. Vegetable oils, for that matter. There's a bit of conflicting evidence out there. They do contain linoleic acid, which is shown to decrease gastric ulceration, but some of the short chain polyunsaturated fatty acids that are found within these vegetable oils have been shown to be pro-inflammatory in humans. So it's something that I would use with caution. Fish oil has been shown it's high in EPA, DPA, DHA, which are all polyunsaturated fatty acids. And there have been some very small studies in thoroughbreds that have shown to be superior than other fatty acids in the reduction or the cessation of gastric ulceration. Beet pulp is another one. It can contain some what are considered protective compounds, one of which is pectin. In one small study, it was shown to be protective against formation of gastric ulcers. Some other really nutraceuticals that are floating out there are fermented soil or rice extracts. They really don't have good science behind them. I thought I would include these other additives just because of the novelty of really all of them. Aloe vera, it was shown in a group of 19 horses to have a reduction of naturally occurring lesions and just over half of that herd, and then some bovine serum proteins that are out there that don't have great science behind them, but are being researched. Another preventative for ulcers is omeprazole. Using UlcerGuard or GastroGuard, which are actually the same exact drug in the same exact tube, just the graduations here on the plunger are different. These are ticks. You get 4 ticks out of 1 syringe on an UlcerGuard. You get 5 250-pound doses on a syringe out of the GastroGuard. And that has been shown to prevent. Now, GastroGuard is very expensive. I'm sure if you've treated a horse for ulcers, you would come to realize that it's not sustainable to keep your horse on omeprazole, particularly GastroGuard, for any increased amount of time. GastroGuard is the only drug that has been shown, the only form of omeprazole that's shown to be efficacious for treating ulcers, and that has to do with the delivery agent that makes up the formulation, which obviously is private for Boehringer Ingelheim. Pulse therapy has been proven to be effective for gastric ulceration. So you treat these horses leading up to a stressful event, you treat them through the stressful event, and then when you get them back home, you stop therapy, which is definitely feasible for most people that have horses when they're traveling to a stressful competition or long trailer rides. This timeline down here shows when you should be giving GastroGuard or omeprazole 30 minutes after an overnight fast on an empty stomach, 30 minutes before the morning feed, and then they're allowed to eat, and that's where it's most efficacious. The supplements, I thought I would include these 3 manufacturers all have some sort of colic package. So if you're feeding this product, typically your horse is eligible for some colic care, for example, from SmartPak, that they'll reimburse you for colic surgery. These are all good products. They don't cure or prevent ulcers, but they do have their place, and they have great incentives for the horse owners. So we'll kind of switch gears here and move on to some common farrier issues or foot issues that are frequently seen on off-the-track thoroughbreds, and that's thin soles. These horses get off of the track and really have no solar depth when you receive them at home. That's because they've been in these shoes all their life, and they're kept to their foot's trimmed so that they have a long toe and a low heel so that they can really dig into the dirt or the turf and propel themselves forward. So the lack of solar depth creates some pressure points on their foot. Ideally, we would like to have a solar depth of at least 1.5 centimeters, and that provides adequate cushion as the horse travels over really any terrain. And if that becomes thin, any sort of firm surface or rock or stone creates a pressure point, and that puts pressure on the sensitive lamina within the sole, and that becomes painful. It's similar to you stepping on a rock without a shoe on. And really, lack of solar depth boils down to management. These horses, as I mentioned, are trimmed in a particular way to benefit them in their current careers, and they're always kept in shoes, and that tends to lead to thin soles, and they become footsore. Some other issues or some other reasons why there could be lack of solar depth are poor nutrition, genetics, less commonly encountered, particularly in the thoroughbred. But if the horse doesn't have great nutrition, they can't grow good foot. And as the common saying goes, no foot, no horse. Genetics, very rarely would it be genetics in the thoroughbred racehorse. This is an example of a horse with very thin soles. As you can see, the solar depth here on this lateral radiograph is 6 millimeters, so it's about a third of what we'd like to see it. This is becoming uncomfortably thin. This particular horse was very footsore on this foot. So it's definitely something you need to keep an eye out on. Mentioned the management, the pathology. As you can see, this horse does have somewhat of a ski sloped distal phalanx, and this isn't a thoroughbred, but I included him as an example for thin soles due to the pathology, because he experienced a laminitic episode a few months prior and began to sink and rotate, which led to a thin sole on this horse and a lameness. This thin sole can lead to solar bruising, and it's similar if we stepped on a rock really hard and bruised our sole. There's hemorrhage in the sensitive part of the sole. This leads to a pressure point, and that foot is in a very dirty environment when you think about where a horse lives. And if you get microbial invasion into this hematoma after they've bruised the sole, it can result in what we see here on the right, and this is a subsolar abscess. You can see this needle has been placed here on this lateral heel, and all of this exudate has just poured out, which is never good and is incredibly painful for the horse. These bruises, they're lame in the interim, and if they become abscessed, then the lameness persists until that pressure is relieved, and then they can go on and fill in that pocket. In this radiograph on the right, we can see on the lateral aspect of this foot, there's this gas opacity, which indicates that this horse had a subsolar abscess. And if the abscesses are chronic and recurrent and don't become resolved, it can lead to what's called septic pedal osteitis. So those microbes invade the actual bone of the foot, this distal phalanx, and you get these resorptive lesions as the bone remodels, trying to get rid of the infection. And that's a clear indicator here that this was chronic abscessation or a puncture wound, and it won't resolve until that bone is debrided and cleaned, and then ultimately re-sterilized, if you will, through surgery. And this is an after picture of that surgery. You can see we went in and took a large portion of that bone when compared to the pre-op film to get back to good, healthy bone, lavage and debride all of the infected bone out, and reestablish healthy boundaries for the horse's foot. Finally here, we'll cover, this is a little bit more my speed, overriding dorsal spinous processes, or kissing spines, or impinging dorsal spinous process. This is typically an overdiagnosed disease process, especially in the thoroughbreds. I'm not saying that this disease doesn't exist. It most certainly does. But some bony changes on the dorsal spinous processes of these horses is documented to be normal. We'll cover a little bit of that later. So on the right here, I have a postmortem spine of a thoroughbred. And thoroughbreds are a bit interesting because their anatomy is a little different. If we look, these are the dorsal spinous processes of the spine. And this is what the saddle sits directly over on the horse's back. And these are the vertebral bodies that they're attached to, and the spinal cord runs down the middle of this tube here. On the thoroughbreds, dorsal spinous processes, they kind of actually flare forward. You can see this, whereas other breeds don't have quite such a dramatic cranial flare. And this predisposes them to become closer and touch each other, as you can see more caudally here in this spine. And they can even rub and be in direct contact and grind. Thoroughbreds, it is a topic of concern in the off the track thoroughbred. It most commonly occurs from the 9th thoracic vertebrae to the 3rd lumbar vertebrae. The most reported are T10, 11, and 12. And it can very rarely go on to affect solely lumbar vertebrae, but it provides, or it inhibits dorsoventral or ventrodorsal movement. So when the horse tries to bend its back up or down, these overriding processes become painful as they kind of grind on each other, and that grinding leads to bony remodeling. The bone responds to the forces that are acting on it, and it will take up bone and put down new bone where it thinks it needs to. And often that leads to complete fusion of these spinous processes. Clinical signs are really vague at times. Oftentimes these horses are presented for reduced spinal mobility. You have to bear in mind that it's a heavy muscled area, and that mobility might not be bony in nature, but could be soft tissue in nature. These horses also come to the hospital and just have an overall general complaint of decrease in performance. Some of these horses, they will throw their riders when they're being saddled, or when they're getting off. That's often a common complaint as well. And when the saddle's involved, it needs to be differentiated between a ill-fitting saddle and actual pathology within the back. So to diagnose this, a physical routine exam is the place where we start. So we palpate the back, we palpate the epaxial muscles, we palpate the dorsal spinous processes where we can feel them kind of from the withers to the SI. And then we move on to a lameness exam and evaluate the horse dynamically to see how the horse moves and if there are any abnormalities that could be predisposing or a red herring for kissing spines. Radiographs are another valuable tool. You can see in this radiograph here, this horse you would think was a tried and true candidate for kissing spines. And this horse actually was presented for a second opinion on kissing spines, and it was in fact not kissing spines in this particular horse, but a soft tissue injury in the distal limb. Sonography is another valuable tool. You can evaluate the remodeling straight from the top on the screen, and it gives you a little bit more of information. Scintigraphy is often used in conjunction with radiographs. So the radiographs tell us that the problem has been going on long enough for the bones to remodel. That's a process that takes time to establish. Scintigraphy allows us to inject a radioactive pharmaceutical into the horse's vein, and then use what's called a gamma camera to take these pictures. So this is actually a picture of a horse's back. The head is to the left, and this is the slope of the withers as it moves down, and then moving towards the rump of the animal here. These are all ribs, as you can see. So that radioactive pharmaceutical is injected into the blood, and then we wait for a couple of hours, and then it travels from the bloodstream and binds to actively remodeling bone. And then we take it and put it in front of this gamma camera, and the radioactive pharmaceutical emits radiation or gamma waves. And this camera can detect those waves, and it creates these dot pictures for each wave that it detects. So this is actually the vertebral bodies of the horse. These are the dorsal spinous processes up here. There's some trace uptake here in these dorsal spinous processes at about T12 to T15, and it gives you another clue. But the gold standard for kissing spines diagnosis is diagnostic analgesia. And it's imperative to know, especially before you take a horse to surgery, that this is the real reason. The last thing that we want to do is operate on a horse that doesn't need it. It's too risky of a situation to do these procedures and not actually be helping the horse. So these needles are placed in the interspinous spaces, radiographically guided, and then we inject a local anesthetic. And if the horse is truly a kissing spine candidate, we alleviate the pain, we alleviate the clinical symptoms, and then we decide if surgery is a viable option for that particular animal. So diagnostic analgesia is the gold standard. Treatment for kissing spines really just is stall rest and NSAID. It's as if you yourself had a pulled muscle in your back, and that's the conservative way. Some people like to inject in the lesion with a corticosteroid that decreases the inflammation, which then helps with pain. There are a few different techniques out there that we'll actually touch on, but some people prefer the interspinous technique. Was the last image on that radiograph. Others prefer abaxial injections on either side of the affected dorsal spinous processes. As you can imagine, these horses become very backsore in their soft tissues, as well as their bony tissues hurt. Their soft tissues start to try to compensate to relieve that. They become muscle sore in their back as well. So sometimes ribaxin or methocarbamol as a muscle relaxant can help quell that pain. And then physiotherapy. Sometimes these horses can atrophy on one side or the other, trying to get away from the pain that's in their back. And strengthening their core, strengthening their back muscles can help through some pretty basic and routine physical therapy modalities. Surgical management, there are a few techniques that are described out there as far as surgical techniques. The first one that was described was the total ostectomy. So you can see in these images here from Walmsley's description, there's a incision directly over the dorsal spinous processes of the horse, and then part of these processes are removed. So the bone is actually removed that's involved. It can be quite the undertaking because, as you can see here, they're left with this zipper-like incision on their back, and no one really wants to manage that. It can be a bit difficult as the horse heals. So some other techniques were then described, the second of which was a very early open subtotal. They don't take the entire dorsal spinous process. In this early paper, they took just the caudal half or the back half of the spinous processes so that they don't override and impinge on each other. And the most recently described was the interspinous ligament desmotomy. So this is a more minimally invasive technique. You can see here in this picture on the right, there are just small stab incisions over each interspinous space. These scissors are put in the interspinous space and cut the supraspinous and intraspinous ligaments that attach these dorsal spinous processes together. And this image labeled C is a preoperative image before those ligaments were cut, and this image labeled D on the bottom right is after. So you can see that this procedure does increase that space postoperatively for these horses so that they're not overriding. But back to really the problem with kissing spines, and it's are these radiographic lesions that are found on your horse truly clinical? So this paper that was out of Europe looked at 582 horses that had perceived back pain, either by the owner, the trainer, or referring veterinarian, and then that were referred in. They compared these studies radiographically and then took scintigraphic images to see if these lesions were actively inflamed based on scintigraphic findings. Most of these horses were thoroughbreds, with 76% of the population being overrepresented flat racing thoroughbreds, with 46% of this population having radiographic evidence of what is considered "quote unquote" kissing spines. So that the sclerosis and the spines appeared to be impinging at each other. Interestingly enough, though, only 27% of those with the scintigraphic exam showed clinical signs when tested. So they performed lameness exams with diagnostic analgesia and proved that it was in fact not the back that was bothering the horse, even though there was perceived back pain and scintigraphic evidence. So This group concluded it is imperative that you perform the diagnostic analgesia before you ship the horse off for surgery, just to have his back operated. This is another paper that was performed in 33 just normal horses to look at, again, the radiographic and sonographic evidence that overriding dorsal spinous processes was an issue. So they wanted to look at the radiographs compared to the scintigraphy. They performed both exams on all of these horses. They were all English disciplines, and they really had mixed results. Only 7 of these horses had no findings radiographically or on scintigraphy. 26 of these horses had mild findings on radiographs and no findings on scintigraphy, and then there were 5 horses that had severe increased radiopharmaceutical uptake, which can be seen here on the image to the right at these dorsal spinous processes, particularly the ones labeled 2 at T15, 16, T16, 17. So if we decide to send the horse for surgery, there's really a decision-making process that needs to happen. Or if we, let me rephrase that, if we diagnose the horse with kissing spines, there's a decision-making process that needs to happen between you and your veterinarian. So this paper, this is a very recent paper that was just published out of Germany that surveyed 353 orthopedic specialists across the world. And that included the American College of Veterinary Surgeons and the European College of Veterinary Surgeons. And they asked them how they treated horses with kissing spines. And interestingly, if you look at this pie chart to the right, conservative management is almost always elected. In 85% of these cases, conservative management is elected over 353 specialists. 15% of these surgeons take the horse straight to surgery, but everyone else decides to either treat with systemic medications, local injections, whether that be corticosteroids or mesotherapy along the apaxial muscles, controlled exercise and manual physical therapy are also always elected. This group found that the Americans were a little more on the trigger to take these horses to surgery than the Europeans were. But the big take-home message is that conservative therapy is definitely preferred amongst the profession when you're talking about taking these horses to surgery. And then finally, on surgical papers, this looked at 18 horses with overriding dorsal spinous processes. They had 17 thoroughbreds that were included, and they performed the less invasive intraspinous ligament desmotomy. And they had some pretty decent follow-up in these horses with a median of over a year after surgery had performed, and they had really good outcomes, with 90% of these horses being improved after the surgery if they did in fact block 2 kissing spine lesions. The ones that weren't blocked and the surgery was performed anyways, they had a 50% success rate. So some of those horses were still back pain perceived postoperatively after having back surgery, based off of the radiographic findings. So again, I think this highlights the fact that diagnostic analgesia, blocking that back and making sure that's where it comes from is definitely key, because you might have something else going on with your horse that is soft tissue and doesn't involve back surgery. And then just to kind of summarize all of these topics, is this paper that Dr. Reed published a few years back, and it surveyed retired or off-the-track thoroughbred owners and trainers, and followed them in their first year of retirement. And it looked at really the satisfaction of the owner and the trainer. And there's some really interesting information in here, because these horses go on to do just about everything other than race, which I think is a testament to the thoroughbred, their second careers and what they're capable of. But when you look at the data that was collected here, 50% of these horses that were retired, and this was something like almost 1,500 horses, only half of those were reported to be actually healthy and sound and arrived that way. And a quarter of these horses were misrepresented on advertisement or however they chose to find the horse. And then 25% of these horses were accurately represented with their known issues. And they compared these to horses that were not off the track thoroughbreds. And they found that off the track thoroughbreds were 14 times more likely to have issues when coming directly off the track. And one of the charts that they included in this particular study is here on the right, and it shows the issues that these horses experienced. So a good portion, half of them, had no issues off the track. But to note, musculoskeletal, hoof, behavioral, and gastrointestinal issues were the ones that were most represented in this study population. And over a third of these horses had musculoskeletal issues. Those are listed here in this table on the right, with hock arthritis and stifle issues being the most reported complaint. Spine issues is fourth on this list, with about 10% of those horses having been reported to have some sort of back issue, whether that's soft or hard tissue. And foot issues here on the right, only 3% of those horses were included with foot issues that involved the hoof or those that are involved inside of the hoof. Osteoarthritis was less commonly reported in these horses, with only 20.5% of these horses having osteoarthritis, and that included all joints, not just ankles and knees. And gastrointestinal issues was reported to be 75% of the horses that were found. Now, admittedly, almost half of that 75% of those horses were just based on the owner's suspicion that they thought the horse had ulcers, and they didn't actually have gastroscopy or a therapeutic trial of medication performed. But it still is a testament that these horses do come off the track with some issues. But almost 100% of the owners that were surveyed in this study would buy or adopt a racehorse again, and they recommend them to a friend. So, these horses can get through these issues that they experience off the track if they're successfully managed, particularly in the first year of retirement. 93% of these owners had no regret, and 76% went on to be used as intended, with over almost half of the horses that weren't used as intended not being used due to issues related to the horse. It was some extenuating circumstance while they weren't used as intended. Only 30% of these questionnaire respondents had a pre-purchase exam performed. A lot of these issues could have likely been avoided had a pre-purchase exam been performed. And the number of starts had no significant effect on soundness. So those that did have a lot of outs under their belt, it had no effect on their overall soundness when they went into retirement. They did find that it did have a significant effect on their gastric ulceration. So, these horses, the first year of retirement from racing, if they're very closely monitored and work with your veterinarian on the issues that you might face, they go on to have very successful second careers. With that, I will take any questions, Kristen, if there are any.
Yeah, I will give everybody a minute to type any questions in that you have for Dr. Manning. But in the meantime, because I am a thoroughbred owner myself, I have my own questions too. So I'm going to kick off with my own. So thinking back on the kissing spines section, it's not just getting a diagnosis, but it's getting that full diagnosis. So not
Correct.
just taking like the x-ray and being like, oh, yep, looks like kissing spine. So if you're doing any of the, kind of like groundwork based, sort of changing how the horse is going to carry himself differently, like what else would that help? Where if you didn't take all the steps to say, get the reds and then get the injection you were talking about, to fully diagnose kissing spine, like if you do that work and you see improvement, can you be like, oh, I guess I fixed it? Like how much can we do on our own before we get to
Certainly.
diagnosing?
It's difficult because you have to consider the whole horse, right? And while there are obvious radiographic changes, or the horse is just moving differently, that doesn't always mean it's the back. So a comprehensive lameness exam is really key to get started, to give both the veterinarian that's looking at the horse and yourself an idea of what's next, when it comes to medical management of those cases.
Okay. We have a question from Kim on Zoom. Is it recommended that all young off-track thoroughbreds be on an ulcer preventative supplement, even if they don't show any symptoms?
Again, this is not my wheelhouse, but I think in that first year of life, or first year of life after racing, I should say, they're going to be stressed out. You know, they go from a stressful environment to not working. That's stressful in and of itself. The problem with keeping them on an omeprazole medication in that time is that we know that feed through omeprazole doesn't work great. The best medication out there, and again, I have no bias or no conflicts of interest when it comes to omeprazole or BI, but there's data that shows the GastroGuard, particularly the carrier agent that gets it into the horse, is fundamental on the efficacy of the drug. So while you could feed through a cheaper version, it's not going to work as great. And let's be honest, 12-month supply of GastroGuard is cost prohibitive for just about anyone. So I wouldn't keep them on GastroGuard in that first year of life, but I would pulse dose them, where, you know, if you're getting them started under saddle or with their new career, then those first few days that you're working with them, I would definitely treat.
Interesting. Yeah. So, and like it used to be, and I think we are, as an off-track thoroughbred people culture, we're starting to move away from this a little bit. But the common prevailing wisdom for years was like, oh, if you get a horse off the track, you should just give it a month of GastroGuard. Or a lot of people were like, oh, just give it the ulcer guard because it's the same thing, even though you mentioned like the dosing is different. And that used to be like just the thing that you did, and I admit I did that with my first one too, because I was like, this is what they say to do in the Facebook groups.
Right.
And I didn't have scope done, but I just went ahead and spent the money. So is there a downside to doing that other than being out the money for the medicine? Like, are you masking any other issues or creating any problems if you choose to go that route?
No, you're just spending money unnecessarily. It's cheaper to get the horse scoped one time and know for certain, and be out less money if it is positive for gastric ulcers. At the practice I was at prior to being at Bluegrass, you could have a gastroscopy performed on a horse for about $350. Whereas a month's supply of GastroGuard, depending on who you're getting it from, is anywhere from $1,500 to $2,000. So it's the internist would kill me. I would say it's not wrong, but
not best practice.
It's not best practice. Yeah.
Yeah. Yeah, that's interesting. And I know, there's other people that anecdotally would be like, oh, we'll just put them on, this sort of more generic form of omeprazole, or, I know people who swear by the aloe as their treatment, they're like, just do that for a month and that'll sort of fix it. But again, it's just a shot in the dark because no one is doing the scope. So
yeah.
Are there other things that could present, like there was a fairly long list of various symptoms for ulcers. Are there other things that could present like that wouldn't be ulcers, that then you're not treating that other thing?
Certainly not out of the realm of possibility. In my experience, those are the most common to look out for. They're they check all of the boxes for an ulcer horse when you start to see all of those symptoms in the same horse. Again, I don't commonly work up horses for ulcers, so the internist would have more information. But in my experience, the horses that I've seen treated and diagnosed with gastric ulcers, 95% of the time present with those complaints.
Okay, and then I have one more, since I'm just going to monopolize the conversation here. Nobody stopped me. So when we're talking about the thin-soled horses, I think that's another common one. Like you get your horse off the track, the assumption is the soles are thin, so you should, some people swear by pulling the shoes and turning them out, and other people say no, you keep them in shoes and encourage more sole depth. But are there other issues that could be kind of pushed to the back burner if you're just focused on like, oh, it's his thin soles and that's what the problem is? Like, is there anything else that we should be doing kind of off the bat when we get a horse home as far as feet go?
Yeah, I would say a comprehensive lameness exam, first and foremost. That is the best bang for your buck when it comes to these musculoskeletal issues. Personally, I adopted a horse while I was in my residency that was a Western performance horse, and had lived his whole life in shoes. And that first year of life, for him, not just being a pasture pet, was grueling for both of us because he was so thin-soled. He's actually one of the radiographs that was in this presentation because he was so thin, and it led to chronic recurrent abscessation. I'm thankful he didn't go on to develop septic pedal osteitis, but it was one of those things that I knew what was going to happen when I got him and saw the radiographs for the first time. The next year of life is going to be a challenge because it takes approximately a year for an entire foot to grow out. So from the coronary band to the toe, that's a year's worth of growth. And these horses need 6, 8, 12 months of growth to establish a new solar margin on their foot, so that it becomes appropriately deep. So start with the lameness exam, and then those recommendations can be made after you have a diagnosis of thin soles as to what you need to do for your horse, whether that be shoes with pads, turnout on soft sandy paddock. Those recommendations can be made after
Yeah, so I think like the theme I'm seeing emerge is, you're going to save money and time and stress on you and your horse in the long run if you get a diagnosis early rather than kind of try the spaghetti at the wall method, and be like, well, my friend said it's probably this, so I'm going to treat with that. So,
yeah.
Okay. How's your horse doing now?
Great, brand new foot. He's out of shoes. It took time.
Yeah,
Painful time.
Yeah.
Painful time.
I think I've had my older thoroughbred I've had now for 7 years, and it's been a long transition, and he's now going barefoot, but I did not do that initially, but did eventually get the hoof rads several years later than I probably should have, and kind of worked on a plan from there after sort of fudging our way through for a couple of years. So yeah, I have learned the hard way as well. All right, we're going to go last call for questions. Sorry, go ahead.
I was just saying, more information is always better early in the process, so you can make an informed decision.
Yes, yeah, we just did the same thing with my husband's horse. We thought for sure it just has some odd hoof shaping. We thought for sure that we would reveal an issue with radiographs, and we did not. Actually, inside it looks great. So it's something somewhere else in the horse that's throwing off the rest of him. So
good news, but frustrating.
Yes, yeah. We're just going to work our way up slowly and try to figure it out.
Yep.
So all right, well, thanks everybody who has watched live. If you are watching the replay and you have a question, you can definitely leave it in the comments on our YouTube, or you can email me at kbentley@therrp.org, and we can pass that on. Kim says, thank you very much. Thank you, Kim. And thank you very much, Dr. Manning and Bluegrass Equine, for sponsoring this webinar. It's been a very informative evening.
Thank you for having us.
All right. Have a good night, everybody.